We have presented a few abstracts at this meeting of ASH. One abstract and one presentation is related to a 4-drug combination including bortezomib, melphalan, prednisone, and thalidomide, followed by maintenance with bortezomib and thalidomide. This schema has been delivered in patients over the age of 65, and the important finding of this schema that is superior both in terms of response rate and progression-free survival in comparison not with the old standard treatment, but what is now considered the best standard of care for elderly patients, that is the combination bortezomib, melphalan, and prednisone. So we are moving on after the deliver of the VMP schema that arrived almost 2 years ago with a new schema that are giving better results. The other very important finding of this study is that we move from the classical twice-weekly infusion of bortezomib, 1, 4, 8, 11, to a weekly infusion of bortezomib. And the finding of these studies is that with the weekly infusion of bortezomib, we reduce the incidence of peripheral neuropathy from 15% to 5% without losing efficacy. Well, certainly 4-drug combination might increase the risk of side effects. It's not one of the most friendly or simple approach you can find, but certainly the toxicity is not too high, can be delivered, is manageable. Even the non-hematologic toxicity is always below 10%. The next presentation will be done on Monday, tomorrow, and this is another very important presentation because we'll compare the combination melphalan, prednisone, and lenalidomide versus the classicals melphalan and prednisone. The finding of these studies is that a combination melphalan, prednisone plus lenalidomide followed by continuous treatment with lenalidomide is significantly superior to the control arm. So we now have another standard of care for elderly patients, another option for those patients, and generally speaking, the combination MPR seems to be a second-generation combination that improves the efficacy of the MPT and lower the toxicity of the old MPT. The major finding of these years is that we, in the last 10 years, improved the median survival of around 2 years in those patients, and we believe we could probably further improve survival in the near future. So for this disease, we have been recently able to introduce in the clinic new drugs that are really changing the outcome and are improving the survival. This is a controversial issue because some physicians believe that we should tailor treatment according to cytogenetics. I'm to some extent of another opinion. I do believe that we should give the best possible treatment to all patients, because if you give more to the good prognosis patient, you will probably increase the cure rate of those patients, while at the same time, if you give the best possible treatment to the high-risk myeloma, you give the best option for those patients. Well, for the future, we are certainly working from one side to the fine-tuning of the schema we do have. And again, the 4 drugs versus the 3-drug combination is a way to improve what we already have. The other major issue will be to try to lower the toxicity and again try to have as few possible side effects from those combinations. And certainly for the future, we have now almost 85 new compounds that are currently under investigation in the clinic. And we hope that from some of them, some new important drug will arrive.